So you will need to wait for the end of the whole session before you can finish that question. Your scores will be fed back to the presenters anonymously, and nobody else will know what they've scored, but we will announce the highest scoring overall. Any questions? Okay, hopefully it should go smoothly.
So you're a chair, yeah. No, you're not. So display the first thing is to display the codes. Yes. No, you just read it. So Martin, how do you project it? No, you can go on with it. So the first thing is participants.
Okay, good evening. Good evening. So I believe that the group that has been left here are the ones that are handling the pre-service presentations. And to that effect, we will have Dan Kan Shikuku, then Dr. Lydia Mwansa doing the presentations. And to start with, I'm guided that you need to scan the code that is projected, and you will use it to evaluate each presenter as they do their presentations. So scan the code that is appearing on the screen, and then you will be using it to guide the presentations. And as you do that, we welcome Duncan Shikuku to get ready with his presentation. And for the interest of time, each presenter, we are going to give them only 10 minutes because we've got 1 hour. So please try to give us, sorry? Yeah, we have 1 hour. So we have 4 presentations. So everybody will have 10 minutes so that we can have 20 minutes for the session, for the breakout sessions, for discussions. So Dan, welcome.
So as Duncan is setting up, so you only scan once. So once that presenter is done, so you score, then you just click next. You go to the next presentation. Excuse me, you know, the timing we have here is 20 minutes each times 4. That's more than 1 hour. When they have prepared for 20 minutes. If they can manage, can you try 15 minutes? What's the jump from 20 to 10 points? Let's see, maybe some of them will say, maybe some will be faster.
Okay, just before Duncan presents, we are being requested to divide ourselves. It's like 3/4 of the group are here. So we need people to join the other group for purposes of feedback. So kindly, we have PhD's results being presented on the other side. So if you are a student or you have an interest on that field, kindly join them so that they can have people to listen to their work. Thank you. You can take your minutes.
Okay, so we start. Hello? Hello? So I want to present the work that you did. This work, in Brazil, they say that I was only carrying the piano, but you are the artists. You are the people who are playing that piano. So whatever you are going to see here is basically what you've been doing. And it's on evaluation of the effectiveness of this updated midwifery curriculum in Kenya, which was a cluster randomized controlled trial in KMTCs. And because of time, I'll not go through this background because we've gone through most of them, but I will wish to emphasize at this point here that ICM in 2021 recommended that midwifery curriculum, at least 50% of its content should be practical based and not theoretical, because midwifery is a practical program. And to this, we also had our in-country review of the curriculum for midwifery, that is the KRCHN, the KRNM, and also part of KRM at the Nursing Council, and this was cascaded at the KMTC level, where you are also able to, excuse me, most of us are on the phones, and it becomes so difficult if you are the teacher and your students are all on the phone. Oh, so you are busy assessing?
Yes.
Assessing me?
Yes. Yes.
No, you will only assess me after I'm done. Yeah. So please don't start assessing me now before I assess you myself. So as I was saying, this curricula was reviewed at KMTC, started at the Nursing Council level, came to KMTC. Some of you participated in this review. An addendum was made, which was cascaded to the KMTC so that you can deliver this EMOC updated curriculum for our institutions. Following that curriculum review, we trained a number of lecturers from KMTC, and a number of them were enrolled to participate in a study. And the main objectives for this study, we just wanted to find out if you review a curriculum and follow it up by training and mentoring these educators on that updated curriculum, can this improve the quality of teaching? And can this translate in an improvement in performance for students? And that is basically what I'm going to be speaking about. So as you are aware, this is a randomized controlled trial where we randomized colleges by region, meaning that we divided the Kenya into the original provinces, that is Western, Nyanza, across the 8 regions. So these KMTCs that participated here, we randomized them, each of them based on the region they were coming from, such that if you are in Coast, Some of you will be in the intervention and some of you will be in the control. So out of the 48 colleges that we had in KMTC at that time teaching this program, we had an exclusion criteria, an eligibility criteria that KMTCs needed to meet for them to participate in this study. And at that time, this was the criteria that I followed. And for us to be able to have this, we did selection of these institutions by the administration following these strict criteria, where that institution at that time needed to have at least lecturers who are teaching midwifery, offering KRCHN for at least the past 5 years, and must have received EMOC equipment so that we are sure we will not have some sites disadvantaged. So following that criteria, 28 institutions were excluded and we remained with 20. Of these 20, 4 of them were training centers, and therefore we did not randomly allocate them. We assumed since they are already training centers, these tutors will be interacting with most of the time the LSTM staffs because of the other interventions that are happening within the same institutions for the same program in the in-service. But the 16 that remained were randomly allocated to either control or the intervention side. And key to note here is that the two arms, both intervention and control arms, lecturers from these institutions, they both received the EMOC training, but those in the intervention arm were mentored for a period of 1 year. And a total of 43 educators from the intervention versus 29 participated in the study. And when it came to the final assessment of students, we had 91 students from the intervention and 45 from the control. We had 2 educators, unfortunately, the ones we call lost to follow up, who dropped out of the study because of one reason. One of them was a principal and could not follow up with the completion of that task regularly, especially the knowledge component. And then unfortunately, we lost one of the educators who was participating in this from Bungoma campus. So these are some of the interventions that we had. Some of you here luckily participated in these studies, so this makes my work even easier. We were giving you knowledge check questions every 3 months. We were observing some of you in the classrooms during your teaching sessions. We were receiving mentoring support in these specific institutions that were intervention sites. And then at 6 months, we had some group discussions with both of you. And then we had the students' assessment, at least after completion of their midwifery modules. Now, for the assessment of these students, this did not happen at the same time, because you realize from your training curriculum, some institutions have clinical sites and others struggle in getting clinical sites. So it was not easy to have this assessment of students conducted at the same time. Important for us to note is that as much as we would have loved to blind, to make you not aware of the intervention, that is not possible in such a study because you needed to participate in it, and therefore not possible for you to be blinded. However, the assessors, those people who are coming to assess you in the institutions, both at baseline and at endline, were blinded. They did not know whether you are an intervention site or you are a control site. And the mentors who participated in this program for the period of 1 year did not participate in the data collection processes. And also some of you lecturers who we managed to meet at the training centers, I'm happy that you did not know the exact assessments we were giving to the students, and we were not even allowing you to participate in the selection of the equipment, because that would have enabled you to know which skills we were assessing, and therefore we believe that the quality of the results here are well represented. I'll not repeat this one. These are things that I've mentioned in terms of the knowledge check. So it's just something for us to note on the knowledge check is that if 3 of you are coming from the same institution, at no point did the 3 of you do the same test at the same time. We randomized the test such that 3 of you, each of you will complete a different test at a different time, but at the end of the year, you will all have completed that same test. For teaching observations that we observed at the end, we relied on the teaching timetables you provided with us for us to be able to at least identify some of the sessions our colleagues can come and observe your teaching exercises. Then after those teaching observations, we always had the debriefs with the teacher where constructive feedback was provided, and then following that mentoring exercise. For us to note the need, whether on the areas we needed mentorship, we had phone calls with some of the lecturers, and also the online surveys that you are completing was also enabling us to know which areas need strengthening within these institutions. For students' assessment, I've also mentioned something. Key for me to repeat to mention on the students' assessment is that we used a specific system. Systematic random sampling was used for our students' selection. So what we did is that we used a common exam that was done for all these KMTCs, and then we ranked the students from the top to bottom. Then we clustered these students into groups of 6, 6, 6. For those classes that had more students that were not divisible by 6, we excluded so that we remain with complete clusters of 6. And then from each cluster, we were selecting the 4th student across the institutions, so that we do not disadvantage some institutions saying, huku tuli-select the bright ones na huku hapana. Then we had 3 OSCEs for all the sessions for the students, and then after the sessions, we had the debrief sessions. They started those sessions by 20 MCQs, which were able to be completed by the students online. Data analysis, we used the intention to treat principle, where all those participants who were eligible and started participating were included. And then we used the parametric tests to have our analysis, because some of them data was not normally distributed. Allow me to skip this thing because I'm being harassed here in terms of time. Otherwise, I would really have loved you to complete this, because it's going to inform the next session that we are going to discuss. So in terms of the results, we wanted to compare, were there any differences between the educator characteristics in the control and the intervention arm? If you look at these characteristics here, there was no difference between the two groups. The youngest lecturer was 28 years, and the oldest lecturer was 63 years. In terms of EMOC training, those who had completed, there was no difference. And I also went ahead and looked at the last performance in the common college qualifying exam, where they do the midwifery exam. Comparing performances between the two institutions, there was no difference between the colleges. Immediately after training, this is what we saw. We had the baseline evaluation in terms of knowledge, and you are at 61.6%. Immediately after training, this improved to 73.3% for all the groups. And when we also asked you to rate your confidence in terms of teaching EMOC on 8 components, initially you were at 3.1, but this went to 4.2. And for both of these, there was really a significant improvement, which we believed that the training was able to contribute to an improvement in your skills. Now, when we assess the estimate of the effects, was this intervention, did it have any impact in terms of knowledge and confidence between the quarters and the study arms? What we see here is that there was really no difference between the scores of educators in knowledge for the quarters, and also there was no difference between the scores of these educators, whether you are in the intervention arm or you're in the control arm. Now, when we looked at the teaching skills, those skills where we came to observe you specifically teaching, at baseline, as we expected, you are all similar. There was no difference. But when it came to the end line results, you can see there was really a statistically significant improvement for those colleagues within the intervention colleges, from 68.9 to about 89.4, which was a 20.5 increment. And when we look at the students' results, this is what we see here: control sites and the intervention sites. Knowledge. The students within our intervention sites performed better not really better, performed higher compared to those in the control colleges. And when you look at the 3 skills, the newborn resuscitation, shoulder distortion, maternal resuscitation, the same picture was across all the institutions, where students within the intervention colleges performed higher compared to those ones in the control colleges. But a worrying thing here is that look at the performance of our students in newborn resuscitation skill for all the colleges, whether you are in the intervention or in the control. None of our colleges, we were not able to at least attain the 50%. We all performed below 50% in that area, meaning that at least these students, they are really calling for support from you for them to be able to better their skills. And even when we combine the same picture, now this last part here is a combination of knowledge and then the combined skills. We still see the same picture where those in the intervention are performing better, at least showing higher scores compared to those in the control colleges. If you look at the effects for the students, they are really significant. There was really a significant impact of the intervention when you compare those in the intervention colleges versus those in the control colleges, both at the knowledge level and in the skills. But when you look at confidence, where we are giving you just a scale to self-rate yourself, we see the same picture, that's just the same way we saw in the educators. There is no difference. Ukipewa chance ya kujirate mwenyewe, you always feel you are better. But when we go to the actual performance, that is not what we saw there. One of the key strengths from this is that this was the first study to ever be carried in Kenya, and using a randomized controlled trial, this is a robust methodology that aims at interventions at a higher level to inform things to do with policy, and use of our multiple methods of assessment at least ensure that our study findings can be corroborated. And then in terms of conclusion, we see a picture that in terms of knowledge, the training intervention improved the knowledge, and the mentoring intervention specifically was effective to at least have our educators perform well in terms of the quality of teaching. And a crying call by the students is that they really need support for them to be better in terms of these skills, since they are almost joining the in-service, and more investments are needed for us to at least also improve our teaching skills so that we can translate these to better performances by the students. Thank you so much, educators, for being so supportive in this. Thank you so much, KMTC and our donors. Asante.
Thank you so much, Duncan, for that nice presentation. We now welcome the next presenter. Remember to rate him based on the code that was presented before the presentations, and then keep the questions for the panel session. Now we give a chance to Dr. Mwanzia to give a presentation.
what really is the WHO definition of a maternal death. So MPDSR, thank you. I was not noticing, I can just hear myself. So I hope my time starts now. Sorry, we lost some few minutes there with the IT. Yeah, but maternal death, WHO defines it as the annual number of female deaths that occur from any cause that is related to or aggravated by pregnancy or its management, and that excludes accidental and incidental causes during pregnancy and childbirth or within 42 days after childbirth or after the termination of pregnancy, irrespective of the duration of that pregnancy or the site where the pregnancy happened. So then this includes also ectopic pregnancy and abortion, pregnancy-related deaths and all that. And the perinatal death is defined as the number of stillbirths or deaths in the first week of life per 1,000 total births. That is the perinatal period that commences from 28 weeks of gestation here in Kenya and ends 7 days completed after birth. So that is a perinatal death, the number of stillbirths and the neonatal deaths that, early neonatal deaths. And so MPDSR really is about surveillance and response towards these maternal and perinatal deaths. And when we talk about surveillance, it's about quantifying, about naming the numbers and then analyzing those numbers and providing those statistics for policy development on how to improve the quality of care that mothers and babies receive. And then when we talk about the surveillance, it's about going back to look at the circumstances around why mothers and babies died, and then instituting quality improvement programs in our midwifery and neonatal units. This thing, okay. So the problem statement, I think, the background, if we can go back there. When we look at the low middle income countries, you notice that midwives have a broader scope of practice compared to midwives, in the upper regions, in the higher economic zones. And midwives, as we have learned from the previous presentation, offer up to 90% of SRM and AH care that is required, and 40% of them, I think the battery of this thing is probably low. Probably I can use this. Hello, can you hear me? I think the battery is going down, if I'm right. Sorry for that. And we have seen that they offer so much of that care, and very few of them are available to be able to offer that care. And midwives have been shown through research to be able to avert up to 3/4 of those deaths if they are internationally prepared in terms of qualification and competencies. And of course, not just the maternal deaths, but the neonatal deaths and the stillbirths. That means that up to 4 million lives would be saved by the year 2035. That is just about after the SDG period. So the problem statement here is that midway into the Sustainable Development Goals, the targets for both maternal and perinatal deaths is off track. If you remember, in the morning, or was it yesterday, the MOH is giving us the statistics for maternal and neonatal deaths. We are still at 355 here in Kenya. In Nigeria, 512 per 100,000 live births. For neonatal deaths, we are at 22. And, we need to be at 70, or at least in our low middle income countries, at 140 per 100,000 live births. And the neonatal mortality burden for these deaths is happening in sub-Saharan Africa and in Southern Asia. So there needs to be a significant increase in the annual rate of reduction for these deaths. So we need to have a lot of quality improvement interventions happening so that we are able to move to the next level of reaching these sustainable development goals. So the objective of our study here was to determine the extent to which MPDSR competencies are included in pre-service midwifery curriculum, and explore the acceptability, demand, and practicality of integrating these competencies, and also establish if there was any legal or professional implications of integrating it, and also explore perspectives of key stakeholders in the pre-service education or about integrating these competencies. So we used a mixed method study design, and first of all, we developed the MPDSR content, module content, guided by WHO and national guidelines on MPDSR, which we validated in meetings with the global stakeholders. And then we used this content to review curriculums in both Kenya and Nigeria from mid-level and university level, so that we can be able to just see how much content is included. And then we had entry meetings where we conducted focus group discussions and in-depth interviews and self-administered questionnaires using interview guides and, of course, review checklists to check on the curriculums. So the study was approved by the IRBs in both countries, both institutional and national, and the sampling was purposive at both mid-level and universities, and we had, that's a correction, a sample of 224 participants who included midwifery educators from 38 universities in both countries and 43 mid-level colleges. We selected them through advices from the regulator and deans and the heads of departments for midwifery to give us, you know, the names of those who would participate. And this was in collaboration with a 3-day CPD program that was happening. So they were all gathered in one place, and so we took advantage of the CPD program to interview them about the inclusion of MPDSR in their curriculum. And we also interviewed the final year midwifery students through selecting them through the deans and HODs. And also we had interviews with key stakeholders with the pre-service task force from the Ministries of Health, the Nursing and Midwifery Council, the Midwifery Association, and of course the principals and deans and heads of departments of midwifery. So we use the WHO ICM Midwifery Competency Framework to be able to review those curriculums against the 8 domains of midwifery educator competencies, and also the ICM Essential Competencies for Midwifery Practice. And you know, this framework ensures that if a midwife is trained, the MPDSR competencies that have been, you know, developed within curriculum using this framework, and be competent in midwifery practice that includes MPDSR, then we are going to have quality improvement and the reduction in preventable maternal and perinatal deaths in our facilities. So for the curriculum review content, we included, we wanted to look whether the curriculum mentions any content on the no-blame culture in MPDSR, bereavement care of the childbearing family, reporting and review of maternal and perinatal deaths, causes and prevention of maternal and perinatal deaths, and evidence-based guidelines in MPDSR, and also the quality of care in maternal and neonatal health. So these are some of the results. We had 108 midwifery educators. 48% of them were from the university and 52 from the mid-level colleges. The majority of the educators had a master's degree qualification. Very few of them had a PhD qualification. And the midwifery students were 86 of them, majority from the mid-level colleges. We conducted 8 focus group discussions and 30 key stakeholder, key informant interviews, and in-depth interviews. So when we looked at the extent to which MPDSR was included in these curriculums, you know, we can see most of the curriculums had less than 50% content in MPDSR, and none of those curriculums that we reviewed had all the midwifery educator core competencies and essential competencies for midwifery practice related to MPDSR. So the aspects that were completely left out was the mention of the use of MPDSR guidelines, whether national or global, bereavement care, and no-blame culture. And then on acceptability, a majority of the educators agreed that MPDSR should be fully integrated into all the levels of midwifery education, but also a majority required upskilling to support both teaching and student learning. So when we interviewed the students, we see that The competencies of the teachers reflected on the students, in that no blame culture and bereavement care was the least covered content that the students mentioned they had covered, and these were students who were stepping out of the program. And we could see that there was a significant difference between the college students, and where the college students, had higher scores in terms of how much they had covered in classification, reporting and review of maternal death, and the quality of care improvement in MPDSR. So the qualitative results, we had 3 themes. One of them, the appropriateness of integration. One participant saying it will help our students relate with their content early enough. Another one, it should be part of the pre-service training. And another one, we need to expand it more and to strengthen that area. And another one, the integration and the standardization must begin with the regulator, meaning that they needed to have clear guidelines within the training syllabi or the training curriculum, or the training guideline in order to incorporate in curriculum. And then theme 2 and 3, this battery is going down. I do have several challenges today, but yeah, so that if I bite a banana, I lose a tooth. Thank you. So the second theme there on guidelines and curricula, we had members stating the guidelines can be somewhat ambiguous. That is the MPDSR guidelines, the national ones. And then currently our curriculum doesn't have MPDSR. Quite a number of the educators had the same sentiments, and people are not well trained on how to deliver the content. And then also about, this is about the barriers, about the midwifery teacher-student ratios. 100 students to 3 midwife educators was a barrier, and also nursing takes quite a number of hours at the expense of midwifery, meaning that midwifery content, adding another, unit would be a challenge. And then, so stakeholders acknowledge the timeliness of this integration and the adoption of the global standards, requirements, and the guidelines to support implementation. And this should begin at the national level from studies. And some of the barriers are also being studied within LSTM, that educator competency deficiencies also affect the quality of the curriculum, the education the students receive. And also shortage of didactic resources and equipment, especially in the skills lab to teach all these MPDSR competencies could pose a problem in curriculum inclusion. And then competency gaps in MPDSR has been shown also competency gap in MPDSR, that is low in-service training and CPD programs for the midwifery educators, has been shown again, as I have said, and this has also been indicated from quite a while ago that even in emergency obstetric care, competencies by midwifery educators is been a problem, and so this reflects also in MPDSR. And of course, the students also indicated their low competencies in bereavement care, of the childbearing family, no blame culture, and this was as a result of the low competencies of the teachers. And also a study has shown there is poor maternity records, keeping and misclassification of maternal deaths. So it means that these competencies are not being taught by the teachers, and the midwifery students are not knowing what to do at the end of their training. So the use of simulation learning in MPDSR also should be useful in creating clinical scenarios where students can be able to get clinical exposure before they graduate. And so this is not happening, and it showed up in our study. So in conclusion, MPDSR, as the regulators, the educators indicated, is within the scope of practice, but it is not included in curriculum. There is a demand to integrate it, and there is a significant gap. And some of the strengths for our study, that it adds value because of the vastness of the data we collected in a multi-country, multi-level way. And it is important for policymakers and the ministry and the regulators of midwifery education to provide guidelines and the proper, clear scope of practice for midwifery in MPDSR. And also the study provides opportunity for stakeholders to enhance in-service training and CPD programs for MPDSR. We cannot generalize these findings, but we will be publishing. Look out for the manuscript. Thank you.
Thank you very much, Dr. Mwanzia, for that nice presentation, despite the fact that time was not quite adequate, but I hope we've been able to get the points. A reminder, keep scoring or evaluating the presenters as we move along. After a break, we will have a panel session whereby we can be able to ask them questions and have discussions. Now we give a chance to Duncan to do his second presentation. Duncan.
Good evening. Good evening. Very good. I assure you this is my last time you are seeing me here. Yes. You know, when an in-law visits too often, he starts being told to fetch firewood. So hope this is the last one so that I don't fetch any firewood here. Evaluation of the feasibility of a midwifery educator CPD program in Kenya and Nigeria. Happy that majority of you in the room here also participated in this, and therefore the things I will be speaking about, you are very familiar with them. So WHO has 8 competency domains that we as midwifery educators need to possess. And these vary from clinical teaching, theoretical teaching in class, all the way up to research. These are competencies that we as educators need to have. But then the flip side is that in 2018-2019, WHO carried a study among midwifery educators in low and middle income countries. And none of the midwifery educators felt confident in all those core competencies that you've just seen there, the 8 of them. And then there's also another problem where most midwifery educators, especially in these developing countries, lack opportunities for them to update their knowledge and skills. And therefore, that is why we also had, in one of the systematic reviews that I'm leading on, we see that there is low evidence of these midwifery educator capacity building initiatives, and that led to the blended program that we developed, which I've already discussed in my first presentation. And being that this was the first program that we had developed for educators, there is need for you to test the feasibility, whether this program is feasible, acceptable, and does it fit the purpose for its use. And therefore we use the Kirkpatrick's framework, where we basically focused on 2 aspects here. We were just assessing here level. Is the program relevant? Does it satisfy your teaching needs? And did it contribute to any change in terms of your knowledge and skills? These are just the 2 areas that we focused on. And basically, broad objective, just in summary, we were basically looking at your reaction. Are they relevant? Are they satisfactory to you? Do they contribute to any change in knowledge? Do they contribute to any change in your skills and confidence? The last objective, which is a qualitative one, I'm not presenting the findings here. It's still under analysis. So this was a cross-sectional interventional study using mixed research methods. And educators participating in these were required to first complete the self-directed online component on the WCA program. And then after that, they were invited to complete the face-to-face program. And participants were all midwifery educators selected from Kenya and Nigeria, 60 each from each country, 30 each for university and mid-level training colleges. And our assessments for level 1 in terms of checking the reaction, whether the programs was satisfactory, we used a Likert scale, 0 to 4, where you are able to express your satisfaction. In terms of learning whether this program was contributing to any knowledge, we embedded knowledge check questions within the self-directed online component. And then we also had a Likert scale at the end of the program that was also evaluating the confidence of these teachers, how they felt after the program in terms of their confidence in teaching methodologies, assessments, and feedback. Then we also had 2 practical sessions where we asked the educators a practical thing to develop a teaching plan And this teaching plan was to be submitted online before and after, and then each of them was given an opportunity to do a micro-teaching session, a session lasting not more than 10 minutes, and this was evaluated against a specific checklist. For our analysis, we use the parametric tests as well, because looking at the distribution of the data, it was not normally distributed. We have some very high scores and some very low scores, and that leading to that disproportionality. In terms of results, our sample size was 120. That is what was our target. And in terms of recruitment, we recruited 120, 60 from each country. But then those who were able to complete the self-directed online component, in Kenya we lost 2, in Nigeria they lost 2. I know one of them experienced serious IT challenges that he was not able to complete that program. And the rule was that you will not proceed to complete the face-to-face program unless you had completed the self-directed online component. And this is where Kenya now, things were not very good. Out of 58, 6 of us were not able to complete the self-directed online component completely, thus giving us those low numbers. But overall, happy that at least 90% of the participants overall were able to complete this. In terms of the characteristics, were there any differences between educators in Nigeria and educators in Kenya? 2 things that emerged here is that when you look at gender in terms of our educators, gender was a key. There was a key difference in terms of gender. For the training of the mid-level educators in Nigeria, out of a class of 28, we only had 1 man. 1 man. Such that the 3 males from Kenya, at least we made some proportion to appear that at least we had men in the room. Otherwise it was... The Nigerian, the men were really quite low, and the same was even at the university level. And then in terms of years of experience as a midwifery educator, majority of the educators in Kenya were between 6 to 10 years, compared to Nigeria, majority of them were over 15 years. There were no difference in whether you had participated in teaching a class before. When we look at whether these participating in the self-directed online component contributed to any change in knowledge for these educators on the 4 modules. As you can see here, there was an improvement in the performance scores for all modules across, which was a good thing. Particularly, one that was really eye-catching was on the students' assessment here. At the start, across all the modules, we were just almost 50% for all of them, but there was a very big improvement in terms of this specific module. And when we look at the next aspect here, in terms of whether you felt these modules were relevant or not on a scale of 0 to 4, you can see that majority of us rated the programs at 4, that you felt that those modules were relevant at 4 maximum. And whether you are satisfied with those modules, again, we see a picture where a majority of us rated 4. And some of the key things that you made was that you found the module content being informative. Most of you said that you joined at least to learn something new, and you are able to learn the new thing. In terms of confidence in the number of items that we were focusing on as you participated in this program, before and after, there was overall a general improvement across all the aspects, but what was really eye-catching for me was this specific part here on using digital innovations in assessments in our teaching. These, before the training, across both mid-level and universities, our confidence in this one was less than half. But after the training, at least we doubled our confidence. And whether the practical modules were relevant to us, again, we see a very nice picture here, where most of you rated the program at 4 out of 4, having been relevant to your practice. And On whether you are satisfied with those practical components, again, we see the same picture. You rated, majority of us rated the program at 4 out of 4 for some of those components, like the teaching plan, lecturing methods, scenario teaching, digital innovations, and such things. Preparing a lesson plan. This was something we really wanted to test. And at the start, when you look at the pre-test, for all the participants, we met most of the items at just about 60%. But after the training, our scores improved to 75%. Good thing is that there was no difference in terms of whether you are from Kenya or Nigeria, whether you are from mid-level university or your qualifications. The scores, there were no differences in terms of those scores based on these 3 items here. On the micro-teaching skills, where each of the educators was presenting a 10-minute session, again, these were the scores across the skills. No differences between the overall scores in Kenya and Nigeria here, in terms of at least statistical difference. When you look at whether you are from mid-level or university, again, nothing statistically significant here. When you look at whether you have a diploma, bachelor, master's, or PhD, although you can see that the PhD colleagues scored higher compared to the, say, master's or the mid-level, but statistically there was no difference if you look at those qualifications, whether they had any impact in terms of you delivering the micro-teaching skill. Whether there was any association, so we were looking at these educators, are you able to meet at least 75% of the items we were looking for? And when you look at that picture, we see that about 60%, just 57.9% of the participants scored at least 75% or higher in the items that we were assessing. And again, here we see a similar scenario. There were no differences in terms of whether you, for those who achieved these components, whether you are from Nigeria, whether you are from mid-level university, or whether your qualifications were contributing to this. Are we still together? Yes. Are you sure? Yes. Take out your phone. Take out your phone, scan that code and answer that question, just to see whether we are together. Are you done? Are you done? Okay. But hope you're able to see the question. You're able to see the question, right? Very good. Fantastic. You reassured me that we were together. You really reassured me that we were together. Now see what we are seeing here. Are you sure we were together? Okay. So that was the correct answer, and that was the immediate slide just before that thing here, just to show that some of us were not with us here. Just conclude. It's the conclusion slide. It's the conclusion slide. So in conclusion, you people said that this is a program that is feasible, relevant, and meets your needs, and it was effective in improving your knowledge and skills as expected, and there is room for further improvement where we need these programs on a regular basis. Thank you so much, educators, for having supported us. Thank you so much. It was very interesting and nice working with you, for your support. Thank you so much, KMTC, and all our funders. Thank you so much.
you once again, Duncan, for that nice presentation. And now we give a chance to our last presentation for this session from Dr. Mwanzia once again. Karibu.
Thank you. That's really reassuring. It's the last one.
Yes, and then there's a small change in the program. Instead of breaking out, we will have the question and answer session here. Then we will have the closing session together with the other colleagues from the other group. Thank you. Welcome.
Thank you, Chair. When we prepared this presentation, we knew we had 20 minutes, so you will bear with the speed at which we go with a mixed method, but we will manage it. So this study was conducted simultaneously together with the MPDSR1, and so we wanted to look also at the feasibility of integrating abortion care competencies in pre-service midwifery curriculum. And for those who want a reminder of what abortion is, it's just termination of pregnancy for whatever reason, whether induced or spontaneous, before the age of viability here in Kenya, before the age of 28 weeks gestation. The problem statement here is similar to what I had mentioned concerning maternal mortalities. They're really high, and the 4 big causes, 60% of the causes of maternal deaths is hemorrhage, gestational hypertension, sepsis, and abortion complications. And so that abortion complications has been a little silent in whether it is a midwifery competency or a nursing competency, where exactly does it belong, and where in our curriculum does it belong in terms of management of pregnancy-related complications. And so I will not repeat a lot of what I have mentioned here in terms of justification. It is similar, and the objectives really are also similar. We wanted just to look at the extent to which abortion care competencies are included in pre-service curriculum for midwives and how acceptable, whether there is demand or practicality in integrating it, and the legal and professional implications, and also explore the perspectives. We use a similar methodology. As you can see, it was embedded in what Duncan presented in the CPD educator program that we were running in both Kenya and Nigeria. And so we used the same model of reviewing the curriculums that we had selected for competencies in abortion care. And the content that we developed in relation to abortion care, using the WHO midwifery educator core competencies and the ICM essential competencies for midwifery practice, we wanted to look at whether there was a mention of the use of abortion guidelines, whether national or WHO guidelines, the abortion regulations, because we know abortion is heavily regulated in both Kenya and Nigeria, but whether that was really being taught in pre-service education, and the medical and surgical abortion legal indications within the restrictions of the law, and also evidence-based practice of post-abortion care. Particularly, we wanted to see whether MVA skills training is included in those curriculums, and also whether abortion complications and the management of the same and quality improvement in abortion care was included. The results are a bit similar also in terms of the demographics of the teachers and the students, but when we look at the curriculums, yeah, it was not so different from the MPDSR1. In fact, for abortion care, maybe just a slight improvement at moderate inclusion of abortion care competencies, because post-abortion care was included in at least 50% of those curriculums. And but some of the content that was within the guidelines, national and global, were entirely missed out in those curriculum, including the mention of abortion regulation, and that students didn't know about it. We will see with the results from the students, a lot of them had not covered it. And then the legal indications and contraindications for medical and surgical abortion was also not taught. Pain management in abortion care, bereavement care, social care, and community linkage, the last three being portions of post-abortion care, which was clearly indicated in the national guidelines for both countries. In terms of acceptability, yeah, majority of the educators had not had any CPD training, but 42% of them said they had no in-service or CPD training in abortion care. 86% of the educators believe that it is a doctor's role and not a midwife's role. So there was a pull and push about who really should take care of these women who come with already an induced or undergoing a spontaneous abortion. And the majority also indicated that termination is illegal in some circumstances. So it means that some also knew or indicated that in all circumstances abortion is illegal, and they were not willing to be associated with it. And then 93% indicated they required upskilling in abortion care competencies so that they can be able to teach it, and they also needed teaching and student learning support in terms of being trained on how to teach it, and also the skills training laboratories to be included with the equipment to support. The students, we looked at, we just looked at several data, but this is what we want to present here in relation to what the students indicated they had learned, you know, as they step out of the program. And you can see there, the least covered content there was the MVA and complicated abortion care. So you can see the university students here, though, they performed better compared to the middle-level colleges in terms of the content that they indicated they have covered at the end of their program. And the qualitative results, one of the themes was about the significance and scope of abortion practice and abortion care, with one of the key stakeholders saying abortion complications are among the big 5 contributors of maternal mortality. This was also shown by the students. And then also another one saying being left out to the other cadres, you know, it's for the doctors and the clinical officers. And then some educators saying educators to get a grip of what is supposed to be taught. So this is about competency as a barrier to teaching these competencies. And then also midwives' own perception. So midwives had a perception of that it is not our role, it's not within our scope of practice. And so it could be a barrier for why we had low levels of knowledge. And then another theme on the guidelines and the curriculum, that this is already in the curriculum, and that is post-abortion care was already in the curriculum, but it needed to be updated. And then another one indicating the midwives would require proper training, so then they have the competencies. And then another key stakeholder said, we just do the pack and not the competencies of manual performing manual vacuum aspiration. And then finally, another one, produce a guideline but not circulate it, then it is as if it's not there. So it means that they were not able to access the guidelines even though they are available online and for free. So the findings show that a majority of the curricula is really minimal with the sorry, I prepared this together with the MPDSR one, so there was a mix-up, but this is true that less than 50% of the curricula had content in abortion care in relation to global standards and even national standards. And the quality of the curriculum really will determine the competencies of the workforce produced and within that training program. And this has also been shown in some Chinese study where the midwifery workforce were at moderate or high level with these competencies. So differences in midwifery workforce between regions and income groups has been shown, and this is also in relation to the education levels and the regulatory environments. And so we see that in the regulation in here in Africa, in Nigeria and in Kenya, there was an issue that was brought up by the participants. So the shortage also of midwives within the region poses a serious gap in how much they can be able to pass on to the students. And this shortage is associated with suboptimal education and, of course, suboptimal quality of care for women experiencing an abortion. So these aspects were reflected in both the bachelor's and the graduate students. So the aspects that were missing are also similar to some studies that have been shown where abortion regulation, legal indications and contraindication of medical abortion which are components of comprehensive abortion care. And as we can see, it's only post-abortion care that was indicated in these two countries, meaning that comprehensive abortion care was not really mentioned, and it is not part because of the regulations. And then also the use of MVA as one of the signal functions for primary health care has been shown to be deficient, and so it was also the same. You know, it is a study of 2012 by Ame here, who is amongst us in this conference, and it is still not indicated in our curriculums. You know, the MVA competency is one of the 7 signal functions of the midwife, including antibiotic therapy, especially for abortion sepsis or even puerperosepsis, the use of uterotonics, anticonvulsants, MVA, and newborn resuscitation. And so there is still a lot of gaps that are required to be filled with the CPDs and in-service training for our educators. And then also midwives' ability to provide this abortion care would be shaped by the functionality and the support of the healthcare system. So if the healthcare system is not allowing clinical exposure for students do not go into the MVA rooms, they are not working together with the doctors and the CEOs who are doing it. So then we see the passing on of this competency is quite a challenge. So in conclusion, post-abortion care competencies are within the scope of practice, are within the scope of practice for midwives, but the legal restrictions do not allow for these other components of comprehensive abortion care within curriculum and practice in both countries, and there is a significant gap in midwifery curricula on abortion care, and this needs to be clarified, especially by our regulator, whether really abortion care is a midwifery scope of practice or it is a nursing scope of practice, because it is a pregnancy-related complication, and there is also a demand for upskilling in these competencies. So the strengths and the limitations for this is similar to what I have presented in MPDSR. We had multi-level interviews and participants for this study. So these findings give us a wide scope of evidence that we can use for developing policy to guide post-abortion care competency training within our curricula in midwifery pre-service education. Thank you. Thank you. Acknowledge our funders and our sponsors.
Thanks a lot, Dr. Mwanzia, for presenting, and that is our last presentation for this session. We now welcome the presenters, Duncan and Lydia. And as they come forward, I will request Mr. Mushemi to energize us so that we may be strong for the Q&A session.
Good. So let us stand up so that we can have enough questions. Very good. So you look at me, wherever you are. So you just stand with your legs apart or astride. Are we okay? So just lift your hands up. So just twist the wrists, just the wrists. Are we together? Are you okay? And keep breathing, don't stop breathing. Very, very important. Okay, go parallel, go horizontal. Now you twist the shoulder. So just both of them. No, not very fast, slowly. The method matters, so slowly. Slowly. Now the opposite direction. So you go on, go on, go on. I increase the speed a bit. Okay. I slow it a bit. Okay. Now, still at that point, the wrist, just turn it clockwise. Just at the wrist. As the wrist. Okay, slowly now, but with energy. Slowly, but with energy. Slowly, but with energy. Slowly, but with energy. Backwards. I don't know whether that one is anti-clockwise. Are we together? Now, as we finish, so don't relax your arms. As we finish, still at the shoulder, again, like you're swimming, backstroke. Are we together? Like you're swimming, it's called backstroke. I don't know. Helen is better at that. So backwards now again. Don't drop your arms, don't drop your arms, don't drop your arms, don't drop your arms. Very good. Thank you very much. I'm sure now you have enough questions. Panelists.
Thank you so much, Maina, for that energizer. So we have a few minutes to have question and answer session to our presenters. And now I welcome the people who have got the questions. Yes. You can have the mic.
So there is 2 mics. The other one is.
Thank you, Duncan. Thank you, Lydia, for the great presentation. It was very interesting. I just have more comments and questions, but for Duncan, concerning your presentation on DPC, I thought very interesting at the beginning of the results. You mentioned that so the results on improvement were different according to the topic after self-directing learning, and I find it very interesting because it means that maybe some things are more difficult to teach through, only online learning. And I just was thinking if you will adapt the package accordingly to the results of the study, because maybe you can, change a little bit things, or if you see that it's not working. And for Lydia, a question from the Togo team was concerning your last presentation. If you already got a paper or report, we can consult. As you said, the study is done. So if we can consult like a paper or report just to see more in detail the results. Thank you.
Thank you, presenters. My name is Dr. Talaso. I'm from Kenyatta University. Thank you, Lydia. And this question goes to Lydia. I was just wondering why you are comparing Kenya to Nigeria. I don't know whether it's part of the funders' requirement, because as you know, given the population of Nigeria and Kenya, they are world apart. And secondly, in terms of MMR, there's also a big gap there. So that's one concern. Then the other thing is the issue of implementation, because we've gotten the study, and there is an issue of now putting it into, it's an evidence-based practice. That's what we need in terms of course, informing us, the teaching and all that. So, and you said there's a demand for upscaling. And I don't know, we have a lot of challenges in our settings, of course, all the institutions. Is there a similarity in terms of the curriculum from both ends as to why now, when it comes to now upskilling these findings from Nigeria and Kenya, if there's any similarity? And number two, how is this going to inform our curriculum? Because some of us are under reviewing our curriculum, of course, once the cycle ends. Because like MVA, you said that it is very low. So how are you going to inform us as the stakeholders of this, to put this into our curriculum? At what level and when are you planning to do this at different stages? Thank you.
Thank you. We take one more question, then we get the responses.
Okay, thank you very much. My question goes to Lydia. One is regarding the post-abortion care, because you still gave us information that there is a lot that should be done by midwives, and the Ministry of Health is only talking about those components of the post-abortion care, but there is a lot that is not being done. What steps is LSTM going to do to ensure some of these are allowed or incorporated into the practice of midwives? Secondly, I have this issue which I don't know, maybe anybody else can clarify, maybe it was discussed yesterday, regarding the maternal mortality. We are told 5:30 by WHO, then ministry is saying 3:55. What should we be able to quote? We are now put in a dilemma. Maybe those who are here yesterday can give us information. Thank you.
Thank you, Daktari. Now we give a chance to the presenters to answer the questions.
Thank you so much, Marion, for the question. It was actually a comment. Yeah, and thank you so much all for, I'm sure you all understand that I'm still under my doctor's prescription not to take hard questions. And I go straight to the comment. Yeah, whether we were going to change some components in the program. Yes, we've received very good feedback from the educators who participated in both components, the self-directed and the face-to-face. And we are planning to integrate this feedback into the training program so that for those who will be taking them at the later stages can have at least something that is very refined. Thank you so much.
I hope, Marion, you're happy with that. Okay, so back to you, Marion, again. About the paper, we have developed manuscripts for both of these studies for the MPDSR and abortion care competencies. So we should publish both, so you look out for the report. But I think you can still get the report earlier before, like in the manuscript. You can be a good internal reviewer before we send it out for publication. Now to Dr. Talaso, why Nigeria and Kenya, really it is about the donor, the funder, and I think because of the finances that we wished that we could have covered more ground, like being to Nigeria, Tanzania, you know, and all these Togo, all these countries that are represented here. But the finances or the funding could not really allow. But for Nigeria, we know that 20% of all the global maternal deaths come from Nigeria. And so it was a keen interest to look at what is happening in Nigeria. And I think you've heard a little more about the Nigerian healthcare system and really why we may have so many mothers dying, because like most of the skilled birth attendants are really so much below the skilled birth attendant that we may talk about here in Kenya. The community health workers who trained for 2 years, and but we didn't really investigate that. But we did come to learn that there's a lot of TBAs and non-skilled attendants of birth out there. But in terms of abortion care and MPDSR, the curriculums in, at least in Kenya, we were like at 50. In Nigeria, they really need to up the game, but we are all of us middle, moderate to low in terms of the competencies in our curriculum. And also, how do we intend to upskill the competencies of the midwifery educators? I really don't know. Of course, Professor Charles Amey is the PI, and in our recommendations in the manuscript, we recommend CPD programs, you know, even blended learning CPD programs on MPDSR and abortion care that educators can access on the WCA platform. And perhaps if there is funding, you know, have skills training for especially MVA competencies specifically for midwifery educators, so that we are able to, you know, spread that knowledge and skill downward. And then to Dr. Chelagat, how do we intend to, you know, support this about curriculum? You know, I think we have so much material already. We have the modules that we have developed with UNFPA. They have funded us, and so it should be available through the regulator, of course, through the policymakers, the MOH, to be able to incorporate. Currently, from next week, the MOH is already carrying out MPDSR guidelines review. So we will be there to support in the review of the national guidelines. And so we should be able to pick it up from the national guidelines to update our curriculums. And I'm thinking the Nursing Council also have already updated. There is some content, about 50% of the global guidelines on MPDSR is already in the updated curriculum, which was done last year, 2022. So there is already a lot of MPDSR content in the training guidelines for BSc nursing. And then in terms of the MMR, the national MMR for Kenya here, we are using the population survey that happened in 2021, that was released just 2022. And also in the WHO statistics is from the national statistics, you know, that they receive. So there is such a big discrepancy. I think that is a discussion, a debate that we need to say, which one do we go for? The WHO puts Kenya at 530. I wish MOH was here. I think our colleague, the MOH, must be in the other breakout. Yeah, so Helen, I don't know whether you have something to say. Did you lift your hand? No. Yeah, so Helen, she had mentioned to me earlier on there is a controversy around this MMR. And so what do we say? So what do we say is a question that we ask ourselves. So for me, I always quote both. For Kenya, it is 355 according to the government and 530 according to WHO. In Nigeria, it's 512 according to the government, but 1,047 according to WHO. So I think these are policy issues that maybe are beyond our scope. Yeah.
I don't believe my question was fully answered.
Yes.
Because I was talking about the post-abortion care, that not about the MBBS.
Yes.
The post-abortion care, because we are only dealing with the components, but the other aspects that you talked about. Have
Yes.
you talked on as a LSTM and seen how best we can negotiate and see how this can be incorporated?
The post-abortion care guidelines have all these components which are missing in our curriculum. So it means that we probably do not consult our guidelines, our national guidelines, when we are doing curriculum review, so that then we can include them in the course contents. So I think that is what we really need to do. And so that when we are having upgraded or updated guidelines from the national level, we should be able to have all these documents on the table during curriculum review, and probably this is not happening. We are not putting them all on the table and making sure, counter-checking that we have included all the updates. Yeah.
I think where I'm coming from is the Minister of Health was telling us that we only talk about the components, not the other aspects. Sorry, I'm dwelling in it too long. Thank you.
Okay. I hope the rest of the people, you can understand where Dr. Chelagat is coming from. She is coming from the comprehensive abortion care versus post-abortion care. And here in Kenya and even in Nigeria, the guidelines are on post-abortion care. But apparently, these guidelines include a lot of the comprehensive abortion care guidelines. From the study, we saw the educators, especially in Nigeria and even here in Kenya, they say, we already teach comprehensive abortion care, but we don't call it that way because we are not allowed to call it comprehensive. We call it post-abortion care.
Just an addition to the same, UNFPA through the Alliance to Improve Midwifery Education has also invested around this area, and they are developing those guidelines specifically around the issues of CAC, PAC, and MPDSR, such that it is a global document that will be disseminated to all countries, so that countries will be able to adapt to what fits them, and the things that do not fit us, we simply do not touch. Thanks.
Thank you so much. Do we have any more questions? Yes.
There's a question
There's a question over there. And I also have a question to Duncan as the mic is being taken there. Yeah. In your study, why was completing the self-directed course a mandatory thing for somebody to go to the face-to-face session? How are they related? Now we can get the other question from over there.
Thank you. This is for Duncan. Duncan, you mentioned that it might be a good thing for midwifery educators to, from the time to time, do some clinical practice or at least clinical observership on the wards. I just wondered how often you've thought that they should do that. And the other question is very practical. You spoke about the need for further improvement with the students' scores in the practical skills. I wondered what you thought would be the best way to go about achieving that improvement in those scores. Thank you.
Thank you. Another question so that we can have a response? All right.
Okay. Thank you. Mine was just a comment for the study that was done for the KMTCs. I like the approach they took. We participated in the study, and true, we didn't know what was going on until the results were given out. But to add on that, what else can be done to improve for the students? Thank you.
The last question.
Last question.
Maybe this is just a comment. This is Liki Masava again from KMTC Garissa. IPAS African Alliance did some projects, I think in Western region, on comprehensive abortion care, and actually it was sanctioned by the Ministry of Health. Perhaps I've heard Mr. Duncan Shuku talk about UNFPA. Maybe it will be good also for you to do some review on what IPAS African Alliance did, because it dwelt a lot on comprehensive abortion care, and it even did a lot of activities, including improving CAC activities and donating instruments for that matter, both medical, abortion, and all those that encompasses CAC. Thank you.
Thank you. Let's have response to those questions as we wait for the next group.
Thank you so much for the questions. I'll start with the question from Emma on why SDL was mandatory for someone to go for the face-to-face. So if you look at the design of the modules, they are both focusing on the teaching competencies for educators. And as earlier discussed in the morning, resources are limited for people to complete the face-to-face components, because for a sustainable system, universities and Kenya Medical Training Colleges need to sponsor their educators for them to be able to go for the face-to-face components. But in terms of resources, where this is something that is not just for Kenya, but something across, especially in developing countries. And then in terms of delivery, there are some components that can easily be delivered through the online component. And reading some of the comments from the educators, it was so interesting that majority of you felt those online components were so good because you were able to complete them at your own time, at your free space, anytime you felt like. So that is an advantage on why we also need to have that. Then coming back to the question by Helen on when should these educators go for clinical practice, I think this is a discussion that KMTC and also the universities need to have. And I'll give you an example of what happens around. For medical students, the doctors go for clinical practice in the clinical settings, at the same time teach the students. But the practice when you come to midwifery education is that midwifery educators rarely go for clinical practice in the wards, but are teaching. So the question usually is, how do you teach something that you hardly practice, and when do you know when it is updated? So that is a conversation that KMTC and the universities in Kenya needs to have. And from the assessments, coming to the comment by Wekesa on how well can we progress, it was interesting on some of the for the feedback we received from the students who participated in this survey across the institutions. A key aspect around supportive supervision by the educators. This was found to be one of the weakest links that students reported, in that majority of them felt that when our educators visit them in the clinical environment, most of us, all we go there and ask the students is, this is what students reported. Are you meeting the objectives? If a student says yes, okay. If a student says no, how is the accommodation? Well, in terms of the clinical practice and what is happening in the clinical practice, whether educators go to the clinical areas at least to see what the students are doing, if a student has a gap in a skill, whether the educator is able to demonstrate to the students in that clinical environment, that was one of the lowest areas for the students, and a call for action for us as educators to improve so that these students can then come out as competent people. Thank you.
Thank you so much, Duncan, for that response. And I think we've come to the end of our session because the other group members are coming in.
There was only one question from here.
Thank you very much. My name is Esther Unza. Dr. Lydia, thank you for your work, but I wanted to look at when you're looking at abortion, post-abortion care, because if we emphasize on CAC, remember there are also legal implications as we push it to the curriculum. So actually, when you look at the advocate for PAC, and PAC is okay because abortion has occurred. What care can you give these mothers to save them instead of leaving them to bleed? But when you look at CAC, CAC emphasizes on there was somebody has become pregnant, yes, can that pregnancy be terminated? So when you look at the legal implication, let us explore that before we bring it on board in the pre-service curriculum, unless we are talking about the PAC, post-abortion care, instead of the CAC.
Thank you. You want to respond?
Yeah, and that is what our study indicated, that although there may be a demand and acceptability of including abortion care competencies in pre-service education for midwives, but there is a barrier of including that comprehensive abortion care, and within the law it is not possible. We can only practice the post-abortion care within the guidelines for the national guidelines. But what I was trying to say is that the components of comprehensive abortion care are out there. Like for the universities, they do problem-based learning, self-directed learning. So all these materials are accessible to the students, but the actual competencies, the doing part of managing this abortion care, that was the post-abortion care part that we were looking at, and there is a very under or suboptimal competency by the educators and the students, and that's what we think that legally it is acceptable to include within curriculum. Yes.
Thank you very much to our presenters, and also for those who have participated actively. I think we can now give them a clap as they go take their seats. Thank you very much. And now I welcome the chair for the next session, the closing session. Mr. Minor.
I don't know who it is, unless we check the timetable.
Good afternoon. How has your day been? Someone is shaking the head. I am sure that means a good thing in terms of what you are coming to do. You know, I think there are some people when they are saying yes, they do like this. Somewhere in the world, I think it's in the East. So I believe this has been a beautiful day, and I hope that our expectations have been met. And I would like to really take this opportunity to thank each and every one of you for the intense engagement, for the interest, for the inputs that we've had today and even yesterday, because you know there are some of us that were here yesterday, but I feel like today has even been more intense. So I wonder how tomorrow will be for those that will be here tomorrow. So it's better that you prepare yourself, have a good night rest so that you can be ready. But anyway, I'm really grateful for the day. I believe that we have had so much information in terms of what is happening, implementation-wise, research-wise, the outputs that we are, capacity building, now in two aspects in terms of our healthcare workers, but also sustained capacity building from our PhD students, who I believe are going to be our next global leaders in maternal and newborn health. And I think it has really been quite engaging. You know, I envy them because, you know, to get such an opportunity as a student to present, to get the input of really brilliant minds, the best in the field. Now I talk to the table there. It's an honor and a privilege, and I really appreciate that this has happened. So I believe your input will go a long way in you know, ensuring that we are molding that African generation to help us tackle this issue of maternal and newborn health. For the seasoned ones, our tutors, our lecturers, our program managers and program implementers, thank you very much for, you know, for all this input that we have had in these 2 days of engagement. I believe this is not the end. What we have really is paves way for even further engagements in this field that we work in. And I believe as part of our side expectation and what we talked about in the morning, we have also made contacts and connections that will, I know some of us, most of us here are familiar with one another, but I'm sure each one and every one of us has met a new contact, especially with our teams from outside of Kenya. I believe and I pray that we will make those contacts personal and professional so that they grow us in every other way. In the maternal newborn health that we are addressing, I believe that we'll do this. I know it has been a press day, and just in case you've not been able to do that intense, you know, networking, getting the phone number here and there, and email, our next session provides us this opportunity. We are going to have a small social networking session. I beg, where's Nafisat? I beg that please everyone remain. That from here, let's proceed to where we had our lunch so that we can have that opportunity to close our day in style, to also network a little bit, to follow up the issues that we've not been able to address within our plenaries or our breakout rooms. Please make use of this opportunity so that we can go on and we can keep this fire burning. We have all that it takes. I think in here, like I was saying during the panel, we have the policy makers, we have the implementers, we have the trainers, and if we all join us, then I believe that we are headed in the same way. It will be part of performing our role in this world. So I think we are so tired. I can see people are asking when will this one move out of there. So I will stop from there so that I don't keep yapping and yapping. But I would want us to close this session now with a mighty thank you from LSTM Kenya on their behalf. We have enjoyed hosting all of you, and we know that we'll continue to meet in these corridors of maternal newborn health and healthcare workers capacity building. So receive our gratitude from LSTM Kenya, LSTM Nigeria, LSTM UK, LSTM Tanzania. We are grateful that we hosted you. In case we did not meet your expectations, forgive us and give us feedback so that next time we are hosting you, we'll improve, we promise. So with those few remarks, I would like someone to pray for us so that we can close the day. No, I can see Professor Ame. I'm not allowed to close if Prof is here. It's just, no, you have to say he has refused. Okay, no problem. So I have the permission to close this day. So I'll ask for a volunteer to pray for us. If we don't have a volunteer in 30 seconds, I'll just volunteer someone if there's something like that. So someone please pray for us so that we can close the day. Thank you. Once you praise, then please let's move up there.
May I request that we stand for a word of prayer? Let's pray. Father, in Jesus' name, we come before your presence this evening. We want to thank you, dear Lord, for the day that has been. We have had a wonderful day, sharing knowledge, sharing lessons learned in the implementation of all the practices that we have learned through research, through practice, to be able to reduce the maternal and neonatal mortality. We want to thank you for LSTM family, starting from the UK, here in Africa, and even the partnering counties and those of us in the teaching fraternity. We pray that we team up together, knowing that we have one purpose, that is to improve the care of the people that you created, that is the families, the mothers and the children, and even the fathers in the families. We thank you for each and every one, Jehovah God. As we finish this activity this evening, we go for networking. We want to pray that you be with us. As we travel home, we pray that you cover us with your blood, that none of us will have any issue, but will arrive home safely. Those who will continue tomorrow, we pray for them, that they will achieve the objectives of the day. We thank you, we honor you. In Jesus' name we pray. Amen. Thank you.
Thank you.